Our speaker today is Dr. Minerva Santo-Tomas, a board-certified cardiologist and long COVID advocate with over 31 years of experience in the medical field. Dr. Santo-Tomas studied at Boston University School of Medicine and Southern Illinois University. After starting her cardiology practice, Dr. Santo-Tomas launched a grassroots not-for-profit called Healthy Hearts Initiative to identify, educate, and provide easier access to effective prevention and treatment strategies for stress to promote health and well-being. Today, Dr. Santo-Tomas will discuss practical approaches and specialized perspectives relating to long COVID. Dr. Santo-Tomas, come on in and join us.
Well, hello there. How are you? And thank
Well, thank
you.
you.
Oh, it's great to be here. I'm delighted to participate in the inauguration of this phenomenal and novel platform to help others gain insight and access into the long COVID conundrum that we deal with every day. I thank you all and I congratulate you all for your hard work and efforts. This is a beautiful, beautiful project, and I'm excited to be a part of it. Um, so why don't we begin? We're here to discuss long COVID, but before we actually jump into long COVID, I think it's important to discuss what COVID is overall, kind of get a refresher course on what COVID is, because without COVID, an acute COVID, you can't really have long COVID. So if we could advance to the next slide. And that's just, I just want to let you know that I have absolutely no conflicts of interest in this talk. This is purely something that comes from my heart and a genuine interest in helping others deal with long COVID. And the next slide, please. So you all have probably become familiar with this little spiky, doodad that we call SARS-CoV-2. To me, it kind of reminds me of these old sticker bushes, when you went to the beach and you were barefoot and you'd step on one of these and then they'd hurt and you'd have a hard time getting them out of your foot, right? Because they're sticky and they're yucky and they're painful. And that's kind of what I think of when I see this image. So it's never been something that I've enjoyed, even though it is kind of cute, but it's only cute in appearance. Otherwise, it's a disaster. Next slide, please. So what is COVID-19? We all pretty much know by now that COVID-19 is a virus that is suspected to have originated in Wuhan, China, in a laboratory, a virology laboratory, specifically dealing with nanoimmunology. So it's a very small particle. It's the smallest viral particle that we know of so far. And it's been designated severe acute respiratory syndrome coronavirus 2. It's a long word. And so we nicknamed it COVID-19, COVID being the coronavirus aspect of it, and 19 being the year that it was first discovered, 2019. And as you see in this slide, you can tell that the viral particle itself has several sections, and the most important one, the one that really does all the damage, is the spike protein, and that's up on like the 11 o'clock, maybe 11:30 position of that wheel, and that spike protein kind of sticks out very much like the sticker bush spikes, and that's what attaches to the host cell. So without the spike protein, we don't have an infection. Next slide, please. So what does it do once you're infected, once it enters your body, whether you inhale it or you eat it or you're exposed to it in other ways? The respiratory access method is really the one that's believed to be the most pervasive. And so what happens? It enters your system and it looks for a receptor on your host cell in your tissue called the ACE2 receptor, angiotensin converting enzyme 2 receptor. Now, in the cardiology world, ACE is a very important player when it comes to blood pressure and maintaining normal function in your blood vessels, because ACE is it's one of the steps that are involved in the tightening of blood vessels. So we call that vasoconstriction. And if ACE is damaged, then it affects the way that our blood vessels function. Now, ACE1, if there's an ACE2, there has to be an ACE1. ACE1 is actually the one that is responsible for tightening of your blood vessels and elevating your blood pressure and affects many of our tissues that way. So what happens is if you block ACE1, you can actually lower blood pressure, which is what our ACE inhibitors, that group of drugs that are used for blood pressure lowering, do. ACE2 actually does the opposite. So ACE2 modifies that response from ACE1. So ACE1 is the bad guy, ACE2 is the good guy. But if you block ACE2 and you leave ACE1 off to party and do its own thing, then what happens is that you end up with an unprotected response to the constriction, the narrowing of blood vessels, and that leads to all sorts of havoc internally at the level of the blood vessel. Now, the other thing that happens is that once this little guy attaches to the ACE2 receptor, it becomes internalized. That connection, that lock and key mechanism, allows the viral particle, okay, with all the horns and all the little doodads, to get absorbed into the host cell. And there isn't just one receptor like this image shows. There's a ton of receptors. There's gazillions of receptors, ACE receptors, in our body. They line almost every tissue in our body. And so what happens is that viral particle then gets engulfed or swallowed by the host cell through the ACE receptor, and it possesses the host cell. It's like when you watch these movies, The Exorcist, you have this demonic invasion of someone's body, right? So what happens is this viral particle invades the host cell and it takes over. It damages, destroys the host cell, uses its surface, its walls, to then start manufacturing new viral particles, and then they get released into the bloodstream, into the system, and hence we become overwhelmed. We're invaded by these little species. So it really is a beast. It's not a nice guy at all. Next slide, please. So what happens is that you start to feel symptoms. So the most common symptoms really are a headache, or you feel kind of run down, you get a runny nose, you, you start to cough, you feel like the muscle pains, and you just don't feel good. Overall, something's happening with your body. Some of the things that happen as a result of this viral particle um, invading your body is that the body's immune response starts to work. So you got all your white cells that start to fight the infection, and you start to develop a fever. Because fevers, as you know, are a defense mechanism. The fever isn't to kill you, the fever is to kill the bug, increase the temperature of the body, making it difficult for the virus to survive. But these viruses are really smart and they're mean, and they know how to overcome the effects of the defense system. So you can get some trouble breathing. Some people develop pneumonia, and to be honest, as it's seen there in the elbow region of that model, some people develop septic shock and they die. And so it's very important to catch this before it escalates to those levels. Next slide, please. So this is a really cute slide. I like it because it has a lot of pictures. I love pictures. This is how it helps me understand what's going on. But it gives you a sense of where you find ACE2 receptors. And as I mentioned, pretty much throughout the whole body. So you've got the heart, the brain, the spleen, the liver, the blood vessels, the gastrointestinal tract, the kidney, pancreas, and the lungs. That doesn't even mention the dermocutaneous system, the skin, and or your muscles. And so it affects almost every system in the body, even your eyes. And the sequela of that is that you become symptomatic. So this is a great slide to remember to keep, because believe it or not, it it addresses the symptoms associated with each organ system. Now, this is just a minimal list of the symptoms. To date, there are over 200 symptoms associated with long COVID, which we'll get into in a moment. So, but these are the symptoms that you start to look for in that transitional period between COVID, acute COVID, and long COVID. And this is why. Look at all the organ systems that are affected. Depending on the number of organ systems affected, you'll have symptoms. So you may have no symptoms. Some people are very fortunate and they don't have any symptoms. They go through it, but not even a hiccup. And then they test because somebody else around them had COVID and they're positive, but they had no symptoms. And then there are those that have had mild symptoms, as we mentioned, the runny nose, the headaches, and just general malaise. But then we have moderate to severe symptoms where you end up in the hospital. We used to intubate people. We really try not to do that anymore because we found out it killed people. Not a good thing. So, but they end up on some things we call vasopressors to support their blood pressure and keep oxygenating their brain and all of those things. So, depending on how many symptoms, it can also determine how sick you're going to be. Next slide. So how do you test? All right. So let's say you've got symptoms and you want to know what you have. Now remember, COVID isn't the only thing out there. There's influenza, which is unfortunately back on the rise because we aren't following the same precautions that we did during the initial outbreak of COVID. A lot of people have laxed with the hand washing, very important. Distancing when they're sick. Those are all things that are helpful to avoid the spread of any of these viruses. But so you can have influenza, you can have RSV, which has become a really popular one now. It's kind of trendy. And then you could have COVID and there are many other viruses, just a common cold even. So you want to know if you have COVID or not, because you need to know if you're going to be treated, if you need treatment. So the three most common types of testing are here. And the one that is most common is the one in the middle, the column in the middle, which is the antigen testing. So that's the one you do at home. You know, you put the thing up the nose or in the mouth, and the nose is really the best way to do it. I don't know if any of you got tested when it first became, when we first became aware about this testing. We go to the testing centers and they take this long, you know, doodad and they shove it up your nose. You thought you were having a lobotomy when they were doing it. It doesn't need to be that extreme, but you want to make sure you get a lot of the mucous membrane scrubbed. You don't need to get a nosebleed, but you do want to scrub well so that you have enough of the membrane cells and the mucus to avoid saying snot on the swab. So that is the one that is the home testing, and we get the results within an hour. Unfortunately, about 50% of our home tests are now falsely negative. And that's happening a lot with the newer variants because COVID is a very smart virus. It reminds me a lot of when HIV first came out, that it kept changing its protein code, and that made it very difficult to treat. COVID is very similar. It keeps changing the little spike area, and it modifies the anatomy, the structural integrity of the spike area. And so we're having a hard time finding adequate treatments because it keeps changing the formula of that spike area. And of course, the most definitive testing is the antibody testing, which is to the right of the column to the right, and that is the blood draw, and that is where you'll see if you have acute COVID, which is active, that's IgM, or chronic or latent COVID, which is you've been exposed to it, and that would be the IgGs. And of course, on the slide, on the image next to it, there's a home test. And I do have a positive one from my family, but it was used, so I didn't think it'd be appropriate. But the antigen test, you'll see that there's always a control line. If there's a positive test, you'll have a red line where the T is. Next slide, please. And so now you know you've got COVID. How do you treat it? Well, Paxlovid has been the mainstay for people that have mild to moderate symptoms, or you are at risk. You have a high risk of developing a higher a higher degree of complication because you're diabetic, obese, or you have some kind of immunocompromised status. So Paxlovid, it's prepared in a little bubble packet, and it is 3 tablets, and you take 3 tablets twice a day for 10 days. Now there's studies undergoing looking at extending it. I may have said 10 days for 5 days. You take 2 a day for 5 days. They're looking at extending that to 10 days. And I just today just saw a review article that compared the 10 days to placebo, and there did not appear to have much of an effect taking it for 10 days. So I think we're back to square one there. But that is one of the most common treatments, and otherwise is symptomatic. So the cough remedies, the Tylenol or the Advil for the pain and the fevers and whatnot. That's really what's available now. Next slide, please. And this is what happens then after the first few weeks, and you start transitioning into long COVID if you're unfortunate enough to go through that. So you have the acute infection, which normally will last anywhere from 5 days to 2 weeks, and you really feel lousy. You absolutely feel like you're going to die when you are sick, and then the viral infection may persist, or you might start to get autoimmune responses, and so it gets delayed for a few weeks. And this is a transitional period. After about 4 weeks, let's say 5 to 6 weeks, if you still have symptoms, this is where we start to consider that you may have long COVID. And by 8 to 12 weeks, you have long COVID. Now, interesting, the symptoms change. Initially, the initial symptoms are related to the acute infection, but as time passes, the symptoms kind of take on a different pattern, and it's almost like a latent response to a chronic immune reaction. Because remember, your whole body is fighting this novel virus that it really doesn't recognize, and so that's what kind of changes as it transpires. You start to feel symptoms, but they're not the same symptoms that you had initially. Next slide, please. Okay, so again, this is on the left, you see a timeline. So the acute infection usually starts to recover within 2 weeks, you peak. But by week 4, you may have a residual cough. You might feel kind of yucky still, but you're normally able to start going back to work. You might not feel like exercising, but you start to feel like you're recovering. Unfortunately, 30 to 40% of people do remain with persisting symptoms, and they do evolve the long COVID. And the long COVID, again, as I mentioned, have specific symptoms. Although it's a very long list, we've seen patterns, but we haven't been able to define a certain set of symptoms because it's so random. Some people have only one symptom, other people can't even walk. They're so disabled, and it can last for months to years at this point. And that's a list of the symptoms there. Next slide, please. All right, so here we are. We're at long COVID, and long COVID has many names. It's called long COVID, it's called post-COVID syndrome, it's a post-COVID condition, long haul COVID, whatever it is, it's horrible. It's absolutely horrible if you fall into this category. And behind the name there, you see all the different symptoms associated with it, including the famous loss of smell and taste, which can last. Some people still have a loss of taste and smell. So there's no specific pattern that we've been able to identify as to how long or how many symptoms people will have. And that's very, very frustrating when it comes to this condition. Next slide, please. Okay, so what is long COVID? Again, it's lingering symptoms that occur, and this slide just is a cute little guy there, a cute little doctor with his different patients that have all these symptoms. But the most important line on this slide is actually on the very bottom. And you need to pay attention to this because this is going to define your disability if you do have long COVID, and that's such that may affect daily life functioning. That is a very important symptom, a very important sign to identify and relate to your healthcare provider, because that may change the course of how you're treated and it's going to affect your life for the next 4 to 6 months, 2 years thereafter. Next slide, please. So by now, you may have been asking yourself, what's a cardiologist doing talking about long COVID? I mean, I'm not an infectious disease specialist. I'm very far from the cath lab or the echo lab or reading EKGs, right? So what am I doing talking about long COVID? Well, actually, what I just described to you is my story. It's my why. That's why I'm here. It's my journey. Um, I have been sick with COVID-19 3 times. The first time, early March 2020, and we believe it was the Wuhan variant because I had been traveling, and I was traveling actually to attend a Botox session. I wanted to do a little side gig at the practice, and I'm pretty good with my hands, so I wanted to add some Botox and dermal fillers to my practice. And I was exposed, and I became very ill, the sickest I've ever been. But I recovered. Then I was exposed to a patient who we screened very aggressively. Our patients, we had them sign affidavits that they had no fevers. We isolated everyone in the clinic, and yet the patient decided to be untruthful. And I came in the room to see her with the mask and everything, but turns out she had a COVID and she had the Delta variant, and I was exposed to that, and I was sick again for about 3 weeks. But again, I recovered. Meanwhile, I had been vaccinated, and I do encourage vaccinations. It does diminish and mitigate the presentation of COVID, and I do believe that it saves lives. So I do encourage that. And lastly, this past December, my mother developed COVID. Her caregiver, who goes to see her twice a week, had it and exposed her to it. My mother's 89, and I went over there to take care of her because I knew that she could die, and she was very sick, sick enough so that I actually considered taking her to the hospital. But I knew she'd die. I knew that being 89, and it was the winter, it was a week before Christmas. So I decided to resuscitate her myself at home. I had all the equipment. And so I stayed with her and received a very high viral load, direct transmission from my mother, who I would not allow to suffer. And I took care of her myself. So I got very sick. First week was so-so, took some Paxlovid, got a little better, mitigated my symptoms, but then the following week I got hammered with COVID. Um, had a very hard time breathing. My O2 sats dropped a little bit. I took steroids. I took, you name it. The only thing I didn't do was go to the hospital because my spouse has a neurocognitive disorder, and I didn't want to leave her alone. So I stuck around. But I was very sick. And thereafter, I started to develop these bizarre symptoms where I couldn't speak. I consider myself to be a fairly intelligent person. You know, I mean, I'm not a genius, but I'm pretty smart, and I have a pretty rich vocabulary. But I'd be talking to someone, and I couldn't think of the word, or I'd get lost in my conversation. I'd end up talking about a boat. I'd start talking about a boat and end up talking about a train. Um, I'd flip my words, which since then I learned is called paraphasic speech, so that I thought I had some type of a stroke with an expressive aphasia, which is an inability to say the words that you're thinking. It was very frightening. Mental fatigue, exhaustion. I kept telling my doctor, I feel like I have mononucleosis, which I had when I was 13. And that's how I felt. I couldn't get out of bed. All I wanted to do was sleep. I couldn't think or process. I couldn't work. And that's how it's been for the last 6 months. I have not worked in 6 months. And I've been fighting with my disability company to pay my short-term disability, which they refuse. They've denied. And now I have legal counsel to help me that. But full disclosure, I'm giving this talk to you now, having long COVID. I have improved, but you might notice that my words get a little jumbled, or I get stuck, and that's still the long COVID. It's been devastating, and it's altered my life, hopefully not permanently, but significantly. Next slide, please. So the big question is who, why, how, and when, right? So who gets long COVID? Why do they get it? How and when? So there's some predictors that they've found, again, patterns. If you're diabetic, if you're obese, if you have lung disease, depending on the viral load, depending on your age and your gender, social determinants. But really, we don't have a pattern. We really don't know. To this day, we really don't have a full grasp of what COVID is, how it happens, why three people could be in the same house, exposed to the same person. One person dies, one person goes to the hospital, and the other one has no symptoms. We don't understand that. None of us understand this. It is truly a novel phenomenon to us. Um, and so some of the theories that result that kind of engage others regarding long COVID is persistent viral antigen, specific cell inflammation, herpes virus at reactivation, Epstein-Barr that causes mono is reactivated. It happened in me, hence my mononucleosis symptoms. And I felt like a teenager all over again, but not in the right way. Gut derangements, microvascular dysfunction, microstrokes, macrostrokes, and then an autoreactive immune response, which is it retriggers itself, kind of like a relapsing recurrent, which is very similar to chronic fatigue syndrome. Next slide, please. And again, these are the different systems that get affected. And again, now we're talking about long COVID. So the symptomology changes a bit. So we might not have the high fevers, but we might have low-grade temperatures. You have muscle aches and pains, which are devastating. I mean, I had left lower quadrant pain that I thought I had a thrombus, and it turned out I didn't. It was just inflammation from the COVID. You get clots, thrombosis. You might have an acute coronary syndrome from a clot in your coronaries. But the biggie is to your left of that slide, and that's the neuropsychiatric symptoms, the persistent coronavirus in the brain, the autoantibodies that lead to brain fog and neurocognitive deficiencies. My IQ, I had a neurocognitive testing. My IQ dropped 30 points. Um, and that's amazing. I mean, we're talking about a traumatic brain injury. My IQ dropped 30 points as a result of this. And again, it's devastating. Next slide, please. Being a cardiologist, I can't ignore the cardiovascular effects of COVID. So here's a nice slide to summarize that. As far as the heart muscle, which is in the 11 o'clock position, the myocardium, which is very important, that's the muscle that helps the heart beat and pump. There's direct and there's indirect injury to the heart, as there is to the blood vessels as well. So you can have direct viral injury, which causes inflammation and can weaken the heart muscle. You can have blood flow or microvascular injury due to little clots in the blood vessels. You can have hyperinflammatory responses. You can get heart attacks from acute clots in the blood vessels. You can have mismatch of oxygenation from clots in the lungs that just doesn't allow the heart to receive enough oxygen through the blood supply. The lining of the vessels in the 12 o'clock position, the actual cells that line the blood vessels are injured and they become inflamed. Again, I mentioned ACE1 and ACE2, and that's what you see at the 1 o'clock position. The cell death, the host cell death, when the virus invades the host cell and takes over and possesses it. Hyperinflammation is just every system in your defense mechanism, every immune response is activated and to fight this beast that's unknown to it. Platelets start to first they aggregate, and then they actually lose their ability to aggregate, so you can't clot, and that could lead to bleeding. And there are other coagulation and blood cell mechanisms, but all of it damages the heart, the blood vessels, and all the other major vascular organs in the body. Next slide, please. So I found this slide, and this kind of encapsulates what someone with long COVID looks like, but not just acute COVID. So I don't know if you could tell, her face looks kind of apathetic, like you just don't care. Um, it's a horrible feeling. What happened to me with the brain fog and the brain injury is that I did not care if I lived or died. For the first few months after the diagnosis, I actually went to a very dark place. This thing messes with your brain, not only anatomically, but mentally. The way you think, how you process things, executive functioning. You just don't care anymore about anyone or anything, and it's really debilitating. See the fetal position, she may be in pain, she just feels lousy, and this was a very good image that I found to kind of depict what I looked like for so many months after COVID. Next slide, please. So again, the to me, the most damaging effects are to the brain, because if you can't think, you can't do really anything else. So the processes are believed to be neuroinflammation, inflammatory responses to the brain cells, and that triggers your brain's own immune system. The brain starts to fight itself. The spike protein can become entrapped in the brain tissue, and it could remain latent, so it's always there, and that could prolong the symptoms of neuro COVID. And then, of course, the blood vessels. There's a theory that the large it's kind of like a ligament, or it's a band that separates the blood from the brain tissue. It's called the blood brain barrier. There's a theory that microclots to the little blood vessels affect the blood flow there and causes it to become porous, and then the chemicals, the damaging chemicals from the cellular reaction, the immune reaction, and from the virus itself could cross into the tissue and damage it directly. And I think that makes a lot of sense, because how else is it going to get to the midbrain, which is like right here? I remember telling the doctor, I feel like I have a sack of sand, a bag of sand sitting on my brain, pushing it down. And I could isolate where the attack was. It was right here. So if the nose, the mouth, it goes straight through, and I would say it goes straight through the back of my brain, and that's where your midbrain is. That's where all of the processes occur in your brain. Your thought processes, your reactive processes, your emotional processes, they're all right here, and it goes straight back. And that is um, one of the major ways that you become disabled from the long COVID. Next slide, please. I found this slide, and it really it resonated with me, because this is exactly what I felt like. I felt like I had a big scribbly wire of a bunch of yarn in my brain, and that's really what you feel like. You don't feel like you're a part of the world. You just feel like you're detached from everything. And I thought that that really depicted it clearly. Next slide. So, what do we do about long COVID? How do we treat it, right? Well, there's a problem here, because we currently don't have any evidence-based guidelines, because we don't have any randomized trials that have given us results as to what to do with this. Though here's the thing, we're 4 years out of COVID. We have patients that have had long COVID for 4 years. I know friends that have had long COVID for 4 years. We don't have any integrated policies for diagnosis, management, or long-term care. We have nothing. We're still at square one. And yet there are millions of people. The estimate is that there's over 700 million people in the world that have had COVID. Greater than 1.1, 1.2 Americans have died from COVID. And right now, COVID is on the rise again. We're at the highest level since February of this year again, with this new flirt. It's such a cute name. Oh, it's flirt. It's a flirty variant. Please, it's a killer. And they're saying that, of course, the effects of this flirt variant are going to be, much milder. But it all depends on the individual and what their predisposing factors are and their viral load. So they can't really state that and have it be a fact. They really don't know. We have no reliable metrics to identify or follow. So there are people that don't believe in long COVID. I didn't believe in long COVID. I didn't think long COVID was real. until I had it. I thought it was like God saying, you see, you don't know everything, do you? When I developed the long COVID, I realized this is a real thing. I've told everybody this is a real thing. They look at me sometimes like I'm crazy because I'm very passionate about it. But we do need studies to provide biomarkers and other metrics that can be used to determine who has long COVID and who doesn't. NIH is currently running a study called Recover. We're waiting for those results. So hopefully we'll have information there. So currently therapy is really symptom directed. They were looking at prolonging Paxlovid therapy, but that doesn't seem to be effective based on the most recent studies. We really don't know. Any of the treatments that were used before Omicron variant came along, they're no longer effective because the spike protein keeps changing. It's such a smart smart bug. So right now it's healthy diet, mild exercise is tolerated. I was told not to exercise at all because I was in crisis for a very long time. They finally told me I could start walking. Antioxidants, glutathione is being used, which I'm taking liposomal glutathione drops. Horrendous taste, horrendous smell. It smells like rotten eggs with dog poop mixed all together. It's absolutely horrendous, but they tell me that it really helps the brain, so I'm taking it begrudgingly. Curcumin, antivirals. I had to start taking valcyclovir, which is for herpes. And that's because the Epstein-Barr virus really nailed my brain. And so now I'm on antivirals. Pulmonary therapy, physical and occupational therapy, olfactory retraining for the bad taste and lack of smell, and support groups. We really don't have enough support groups. And this is a life-altering condition. So that would be very helpful. Next slide, please. Okay, so this is from an article that was published in CNN in April of 2022. And back then, just to put it into some type of a concept here, they estimated back then that there had been a cumulative cost of $386 billion in 2022 in lost wages, savings, and medical expenses in the US alone as of January of that year. I guarantee you that that has doubled since then. And I'll tell you why in a minute. Next slide, please. So this is the part that I really wanted to home in on with you all, because once someone is sick enough that they can't think, they really can't work. And so how do you manage medical leave of absence? This is something that most people have to learn on as it happens. Now, if you have brain fog and neuro-COVID, you can't think. You can't be your best advocate. You need an advocate, which is where you guys come in. Because there are no metrics, because it's non-palpable, you can't feel a mass, you don't see a blockage in an artery unless you've had a heart attack, which can happen. There's a stigma. And you really feel like, I put caca, you know what the other word is. You really feel bad because you can't function, you can't think for yourself, you don't care. It's really you feel detached from everything. And so now you have to start thinking about medical leave of absence, short-term disability, long-term disability, the Family Medical Leave Act, FMLA, to protect your job if you're out of work because of this, because you just won't be out for a few weeks. Most people are out for months. Now, the standard federal guideline for FMLA is 3 months. Once you've used up 120 days, you're no longer covered. There are some states that provide coverage, so it really is up to your employer as to whether or not they're going to let you go if you're out for more than 3 months. I've been out for 6 months. I work for Cigna, and they have been so generous. They've preserved my position and they're waiting for me to get better. But now I'm having to pay for my own health insurance because it's already been too long. My short-term disability has been denied. I'm working on my long-term disability. I've had to get an attorney. It's been a mess, but I've had to learn this on the go because I've never been sick in my life. And being a doctor, I don't know what the heck to do. We treat people. We don't do this kind of stuff. So where do people go to get this information? That's where you guys come in. So right now there's a tremendous economic burden. Okay. How do you survive? Where do you find your references, your resources? How do you get loans, financial assistance if you don't have the money and savings to survive these few months? That's information that would really be helpful to patients, clients, providers, to enable people to get through this very difficult period. It's a very dark period in people's lives. I guarantee it. I've gone through it and I'm continuing to go through it currently. Next slide, please. Okay, so this is a busy slide, but basically it just goes through some steps on to how to kind of help the healthcare professional enable the patient to return to work. And so there, it goes over some questions and some points that you want to address. You can look at this later, but it is a very busy slide and I'm running out of time, so I don't want to belabor it. Next slide, please. So what qualifies people for disability if they have long COVID? All right, so the first paragraph, if you see the second line, ADA, according to ADA, long COVID is considered a disability if it substantially limits one or more major life activities, such as caring for oneself, performing manual tasks, working, or sleeping. When you have long COVID, all of these are nailed. You're done, okay? So these are things to focus on if you're going to help people with the medical leave of absence and the disabilities. Now, they go on to say that the brain fog due to long COVID may qualify for disability, and it does. Neuro COVID is an indication because if you don't have healthy executive functioning, if you can't process, if you can't apply things, you can't work. And that's what happened to me, and that's what I'm still going through. My verbal skills are very good. If I had to speak to you and do something else, I'm done. I go into a trance, deer in headlights, and it still happens to me today. If I do something that requires a lot of energy, we talk about energy, um, what's the word? Sorry, I'm having a brain fog moment. Energy bags, let's say, energy aliquots. We talk about energy aliquots in the sense that you have to save up energy if you're going to do something with long COVID. This is how you start to think. Can I do the laundry today and cook dinner? Maybe I'll just cook dinner today. I'll do laundry tomorrow. Can I take the dogs out for a walk? I don't know, it's hot. Maybe I'll do it, at night. You start to allocate when you're going to do things because you can't do it all at once like you used to. It's really very limiting. Okay, next slide, please. This is a great reference. I posted just the title of it. It's about a 3 or 4 page reference. Everyone should have access to this because this gives the healthcare professional and the patient, remember that, the language you need to apply for disability, not just Social Security disability, which, by the way, long COVID is payable as a disability, but you have to meet certain criteria. Okay. And Social Security denies 30% of all they only approve 30% of their claims initially, so you might have to appeal it. But this is a great reference. You go to ssa.org, no, sorry, ssa.gov, and you can find this. And this is a very important reference that you all should keep if you're going to be helping others deal with their long COVID claims. Next slide, please. Okay, mental health. Basically, this is an article about mental health. It was published in 23, and it just talks about the amount of people that have had long COVID, people that suffer with the mental health impact and their symptoms of long COVID. And again, I just wanted to show it to you if you want to refer to it later. It's a very interesting read, and you learn a lot about the neuropsychiatric as well as the neurocognitive effects. I underwent neuropsychiatric and neurocognitive testing. I left there crying because I realized that the amount of damage I had to my brain was incredible. People had to keep validating to me that I had this. I couldn't believe I had this because, I don't have any sign of it except on the inside. And that's really where it all happens. So that's part of testing that is very helpful. It does provide a metric to the insurance company so they know that there's really a problem going on. Next slide, please. Okay, this is a must read. If you're going to read anything, this was published in April of 2024. It's called Economist's Impact, and it's a wonderful summary of everything we know about long COVID right now to date. And it's going to talk about the social impacts of it, the economic impacts, the healthcare impacts, the costs, everything. It's a wonderful read. It's a long article, but everyone should read this. I would even recommend that that patients read this if they want to learn about it. And it was supported by Pfizer, which I think is wonderful because they've really been in on this from the beginning. I did not feel that it was skewed in Pfizer's favor at all, which is this is what doctors look for when they read an article. But you're going to learn a lot about COVID, especially the burden of long COVID on society and what we're looking at as a nation, as more and more people are diagnosed with this condition. You know, the thing is that COVID was so horrible that if you were lucky enough to survive COVID, you might end up with long COVID. So even though you escape the bad guy initially, you might end up with repercussions as a result of surviving it. And it just changes the way you think about life. There's before COVID and there's after COVID. And I think that's how many of us are looking at COVID these days. Next slide, please. Okay, so in summary, this is my summary page. Sorry, I've been talking, which I guess is what I'm here to do. But we need a multidisciplinary team approach. So this is highly important. I think that CompendiaRx has the opportunity to provide this. Why? Because patients that have brain fog and can't think for themselves and have pathologic fatigue, they cannot be their own best advocate. So they need an advocate, and that's where you guys come in. A team approach saves lives. So you need primary care, infectious diseases, neuroimmunology, neuropsychology, neurology, cardiology, pulmonary, you name it, all the ologists that you can get. But you also need social workers. You need support groups. And you need a disability attorney because you're going to need help getting disability for your ailment. And it's a real ailment. And a lot of people just don't understand that. Um, Reassurance and supportive measures are imperative. People are really in a dark place when they get this because they don't understand it. You can't process it. It doesn't make sense. And so it's an imperative to maintain a patient's morale. Um, It'd be great if somebody could prepare a list, a questionnaire with a montage of signs or symptoms that are closely associated with long COVID. And right now, as I mentioned, there are over 200. Because memory loss prevents patients from remembering their symptoms. I would go see my neuroimmunologist, Nancy Klimas. She's world renowned in chronic fatigue syndrome and now long COVID. She would ask me what my symptoms were, and I'd look at her like, "Oh, I don't know. Yeah, I'm tired." Well, no, they need more information. They need details, and so this having that type of information would be very helpful. Diagnostic strategies. We need to start preparing diagnostic strategies as long as long COVID is suspected. So to have a list where patients can go or have already a place where they can go to have these testing, serology, blood work, and whatnot, neuropsychiatric testing, stress testing, all of that is helpful because that provides a metric, an image where the disability company can refer to. I was denied I was denied short-term disability because I didn't have a fever and have a red eardrum. The nurse that was reviewing my case was asking why I didn't have a fever and why my eardrums were not injected, weren't red. That's what she based her denial on. So even the nurse reviewing my case didn't understand what long COVID was. And that's what happens to a lot of people. A lot of these providers, even when they're seeing their patients, they don't understand it's a whole different entity. It takes on a whole different parameter on its own. Monthly visits. It's important to have follow-up with your patients. My doctors, I was diagnosed in February. It took me until April to get tested. And even then, it took another month to get my results. Expedited testing and results are very important to be able to get approved because these insurance companies will deny you. They're looking to deny you. They're looking for a reason to deny you. If they don't have the information, then you're out of luck. And so it's very important to schedule visits and to provide test results effectively, get the notes out to the insurance companies effectively. Doctors don't have time for this. So if there's a platform that can assist in this, would be very helpful. And then integrative mechanisms of communication. People need to talk to one another. My neurologist doesn't know what my neuroimmunologist is doing. My hematologist doesn't know what my neurologist is doing. The attorney seems to be the only one who knows what's going on, and they're not even a clinical species. So I'm flabbergasted by how no one really talks to each other. And I'm a part of the system. So I can only imagine when a member of the public, when laymen go through this, how frustrating it must be. Next slide, please. Okay, so we still have a long road to go regarding COVID, long COVID, and neuro COVID. I think that we're making some strides, but there's still a lot to learn, and that's where folks like you all at CompendiRx will become very helpful, because if you have an integrated, cohesive location where people can have easy access, be it physicians or patients or attorneys or whatever, you can really help change a patient's life. People will feel better, they'll feel reassured, and you may end up saving lives. As I said, this is a life-saving journey that you're embarking on. And again, I congratulate all of you. I wish you all of luck in your endeavors, and I'm eager to see what happens with this. And again, now if I'll open it up to any questions if anyone has questions at this time. And thank you very much for allowing me to participate in this wonderful, wonderful endeavor. Thank you.
Thank you so much, Dr. Santo-Tomas. That was very informative, and thank you for sharing your story as well. It's great to hear from somebody who has a clinical perspective and the perspective of a patient with long COVID as well.
Thank you.
Yes. We do have time for a couple questions, so let's get right to it. First question is, how do primary care providers diagnose long COVID?
It's really symptom based. The patient normally would have had COVID. Now, they don't have to have had a serious case of COVID. Actually, the most common patient that has long COVID nowadays are patients that had either no symptoms or very mild symptoms. So it's all about asking the right questions. You need to ask the patient and let the patient tell you what they're feeling. And you have to ask specifically about the targeted organ system. So, thought processes, do you feel like you're a little bit off? Address the possibility of brain fog. The fatigue is very important. Post-exertional fatigue, malaise. And it doesn't just mean physical exertion, it's mental exertion too. I know that after this talk, I'm going to go take a nap, because that's what my body and brain are going to ask me to do. And that's what happens. You only have enough energy reserves to do one thing at a time. So those are the type of questions. And again, it's all symptomatic at this stage. We don't have an effective biomarker, a blood test to say, okay, let's do this and see if you have. It's a quandary of things. It's a whole bunch of different immune responses, and they're out there, but they could be associated with other conditions as well. So it's kind of like putting a jigsaw puzzle together.
Thank you for that very thorough answer. We are out of time, everybody, and to respect your time, we do want to end on time. So thank you again, Dr. Santo-Tomas, for that wonderful presentation.
Thank you.
Yes. At CompendiRx, we are committed to continuing the discourse and learning about long COVID. There is such a need for ongoing learning and pragmatic discussions for those impacted, healthcare professionals and researchers alike. Please refer to the CompendiRx platform for resources. We are in the beta version of testing that will be live soon. Dr. Santo-Tomas, again, thank you for joining us. Our
Pleasure.
audience, we thank you for your time today, and we hope that you will join us for our next session on August 3rd at 11 a.m. Eastern Time, where we will hear from Jackie Leon, doctorate in naturopathic medicine and board certified in holistic nutrition. Again, thank you, everybody, and I hope everybody has a wonderful day, and please be well.